All right, let's dive right into this clinical case sprint covering renal syndromes, trauma, and nephrolithiasis. We're moving fast, so let's hit our first case.
Imagine a child is brought into the ER. They've got muscle weakness, fatigue, they're constantly craving salty foods, and showing abnormal drinking behavior. You run some labs and find chronic hypokalemia, hypomagnesemia, and metabolic alkalosis. A urinalysis shows marked hypocalciuria, but the renal ultrasound? Completely unremarkable. So out of Bartter syndrome, Gittleman syndrome, Fanconi syndrome, Little syndrome, or congenital adrenal hyperplasia, what is the diagnosis?
If you guessed B, Gittleman syndrome, you hit the nail on the head. The absolute key here, our big exam pearl, is the calcium excretion pivot rule. See, both Bartter and Gittleman feature that chronic hypokalemia and metabolic alkalosis, but look closely at the urinary calcium. In Gittleman syndrome, it's markedly decreased. That's your hypocalciuria. Bartter syndrome, on the other hand, gives you hypercalciuria. Basically, Gittleman acts like a continuous thiazide diuretic, hitting the distal convoluted tubule, whereas Bartter mimics a loop diuretic. Plus, Gittleman usually shows up in older kids or adolescents, not infants like Bartter.
Next up, a patient rolls into the surgical ER with sudden, agonizing left loin pain. It's migrating inferior anteriorly, straight down into the groin, and radiating directly into the left scrotum. Based on that classic dermatomal referral cascade, where exactly is the obstructing calculus lodged? Are we talking the calyceal system, the upper, middle, or lower third of the ureter, or the PUJ? The correct answer is D, the lower third of the ureter. This is a brilliant example of pain migration mapping. As an acute stone leaves the renal pelvis, its movement mechanically stretches the muscular wall. That distension sends pain signals right alongside sympathetic nerves back to your T11 to L2 spinal cord segments. If the obstruction is up high at the upper third or PUJ, the pain is purely in the flank. Middle third, that pain shoots anteriorly across the inguinal crease. But once that stone hits the lower third or UVJ, bam, the pain refers straight to the external genitalia and upper thigh via those L1 and L2 nerve roots.
Okay, picture a patient with severe migraines who's been on long-term methotrexate therapy. They come in with progressive, generalized weakness and an elevated serum creatinine. You get an IVP, and the imaging shows bilateral hydronephrosis. No interluminal stones or masses anywhere, but both ureters are compressed and literally deviated medially toward the midline. What's the most likely diagnosis? It's A, retroperitoneal fibrosis, also known as Ormond's disease. What we're looking at is an inflammatory process where this dense, fibrotic plaque completely encases the great vessels and just squeezes the ureters. The visual footprint on an IVP is classic. You've got bilateral hydronephrosis, extrinsic ureteral compression, and that signature medial deviation of the middle third of the ureters. And don't forget the pharmacological link here. Drugs like methotrexate and beta blockers are notorious secondary drivers for this condition. Next case. A 20-week antenatal ultrasound spots a non-visualized left kidney. After the baby is born, the urology team wants a definitive evaluation to rule out pelvic ectopy and confirm what they suspect is congenital unilateral renal agenesis. What's the absolute preferred diagnostic imaging tool for this? The gold standard here is B, magnetic resonance imaging. Sure, an ultrasound might show an empty renal fossa, but an MRI gives you that high-definition tissue resolution you absolutely need to rule out a tiny dysplastic unit or an ectopic pelvic kidney. The high-yield takeaway here is the hypertrophy sign. When you do follow-up imaging later, you're almost always going to see the remaining solitary kidneys showing massive compensatory hypertrophy, frequently measuring way above the 95th percentile just to keep up with total renal function. Let's look at a 32-year-old guy coming in for an evaluation. Both his dad and his paternal grandpa ended up with end-stage renal disease thanks to autosomal dominant polycystic kidney disease, or ADPKD. We need a safe way to screen him and potentially his other family members. What is our preferred first-line diagnostic imaging modality? It's D, ultrasound. It's totally non-invasive, has zero radiation, and is super cost-effective for a first-line screen. But you really have to memorize the strict, age-dependent diagnostic criteria for ADPKD. If your patient is under 30, finding just 2 cysts total is enough for a diagnosis. For someone aged 30 to 59, like our 32-year-old right here, you need to see at least 2 cysts in each kidney. And for patients 60 and older, that threshold bumps up to 4 cysts per kidney. We really only escalate to a CT scan if things get complicated, or an MRA if we're worried about intracranial aneurysms. Moving on to trauma.
A hemodynamically stable 44-year-old man takes a high-velocity blunt trauma straight to his left flank. You get an urgent abdominal CT with IV contrast, and it shows a localized, non-expanding paranephric hematoma. This puts us at an AAST grade 2 renal injury. What is our optimal management strategy? The correct move is B, non-operative conservative observation. This is one of those incredible clinical realities. Over 90% of blunt renal trauma injuries are actually perfectly stable and can be managed without ever stepping foot in an OR. For a grade 2 injury like this, it basically means strict bed rest until the gross hematuria completely clears up while you keep a very close eye on their vitals and blood counts. But why does that conservative approach work so remarkably well? The fact that we can safely manage the vast majority of blunt renal trauma non-operatively comes down to pure anatomy. Which highly protective compartment are the kidneys sitting in? The answer is B, the extraperitoneal or retroperitoneal space. This is a perfect example of a natural structural tamponade. You've got the kidneys tucked deeply into those tight paravertebral gutters, tightly wrapped in Ureter's fascia. Unlike the very compliant intraperitoneal cavity, this confined space naturally restricts hematomas from expanding and physically puts a stop to the bleeding. Contrast that with penetrating trauma like a stab wound or a gunshot. That directly tears through Ureter's fascia, completely ruining the tamponade effect, which is why those cases end up in surgery far more often. Next question. We have a stable trauma patient who just got a contrast CT after a nasty crush injury. The scan reveals a deep 5.5 centimeter parenchymal laceration tearing through the cortex and going directly into the renal collecting system. There's also a non-expanding hematoma. Based on the AAST staging criteria, what grade are we looking at? That is a grade 4 injury. Answer D. The AAST grading rules here are incredibly straightforward. Grades I, 2, and 3 are all about hematomas and lacerations that do not breach the collecting system. But the absolute second a laceration cuts into that collecting system, causing urine or contrast to leak out, it instantly escalates to a grade 4, regardless of how deep the cut actually is. Grade 5? That's strictly reserved for the worst-case scenarios, a completely shattered kidney or a total avulsion of the main renal pedicle. Let's try one more trauma scenario. A 28-year-old male comes in with severe left flank pain and gross hematuria after taking a direct punch to his left flank. His vitals are totally stable. What is the absolute most appropriate next step to evaluate this specific urological trauma?
You want A contrast-enhanced CT scan. For any stable trauma patient with gross hematuria, a CT scan with IV contrast is the undisputed modern gold standard. It gives you pristine detail of any parenchymal lacerations and perfectly maps out the retroperitoneal hematoma burden, completely making old-school IBUs obsolete. The big rule to remember here is this. The only, and I mean only, time you ever bypass this scan is if your patient is in persistent, uncorrectable shock and needs to be rushed straight to the OR for emergency surgery.
Let's pivot to metabolic stone management. A patient just had their kidney stones surgically removed, and the lab analysis confirms they are pure calcium oxalate monohydrate. What specific dietary change should we recommend to actually stop these from coming back?
The correct answer is C, moderate dairy restriction. The trick here is managing excessive high oxalate foods and regulating calcium, which usually means cutting back on massive amounts of milk and cheese. But you really have to watch out for the paradoxical calcium balance rule. Yes, you avoid massive calcium loading, but severe restriction of dietary calcium is actually contraindicated. Why? Because if there isn't enough calcium in the gut to bind to oxalate, all that free oxalate gets hyperabsorbed into the bloodstream, paradoxically causing way more stones to form. Next up, we know nephrolithiasis can follow all sorts of metabolic and environmental pathways, but in which primary kidney stone variant is the underlying cause classified as completely idiopathic in up to 70% of documented clinical cases?
It's A, calcium oxalate stones. These account for up to 85% of all kidney stone cases. And what's crazy is that in roughly 70% of adults who present with these hypercalciuric stones, the primary metabolic driver is just completely idiopathic. There's no systemic hypercalcemia to blame. That's a huge contrast to other variants. Cysteine stones, those are definitively driven by a known amino acid transport defect. Uric acid stones, they specifically require a highly acidic environment with a pH below 5.5 to form.
Last case, let's bring it home. A 37-year-old guy shows up in absolute agony. He's got recurrent waves of sudden pain, starting in his left flank and shooting straight down anteriorly into his groin. No dysuria, no fever, but you dip his urine and find a positive red blood cell count.
What is the most likely diagnosis? The correct answer is B, nephrourolithiasis. That classic history, the severe rolling flank pain radiating straight down into the groin, is the textbook definition of acute ureteric colic caused by a stone mechanically tearing its way down. Pair that with microscopic hematuria, and your clinical picture is locked in. Recognizing these rapid, distinct clinical patterns is exactly what bridges your textbook knowledge right to the bedside. Ultimately, it's what saves patient lives. So are your clinical reflexes sharp enough to instantly spot these patterns the next time someone walks through those ER doors?